Now that we've looked at the processes of dying, let's take some time to examine physical symptoms that we may see with our patients as they are approaching their death. Even though none of us are God and we can't know exactly what will happen or exactly when someone will die, we can do a pretty good job coming up with a best guess based upon common occurrences that we see. As we talk about various physical, emotional, and spiritual changes, we will also consider what we can do in those moments to help our patients and to help their families. I'll try to share some different stories and examples as we talk about these aspects of dying. I worked for about 8 years in long-term care as a CNA, and then later as social services director of a large skilled nursing facility. I've also worked in hospice, and throughout these experiences, I have been blessed to sit with many people as they died. Some had families there, others were all alone. Through these moments of sadness, I was able to experience shared moments of joy, serenity, forgiveness, and release. Not all deaths are horrible and painful. In fact, my goal was and will always be to help death be as comfortable and peaceful and as spiritual as possible. Here we see some common symptoms of dying patients. Not every patient experiences all these things, some do and some don't, but it's important for us to be aware of so we can try to help make them as comfortable as possible. Having this understanding will also help us as we try to prepare families for what may be coming soon. As people become more frail and weak, as their physical health declines and they don't have the energy they used to, they become less and less involved in what's happening around them. It may require too much effort to get out of bed and get dressed. It may seem overwhelming to try to be around a lot of people or even to interact with others. As people face death, they begin to socialize less and rest more. This is normal and natural, and it makes sense that if someone isn't feeling good or they don't have a lot of energy to move around, that we should not try to force them to be active or even to have lots of visitors. Rather than having a bunch of people in the room at once, you can encourage family members to take shifts, take turns, if you will, sitting with mom or dad or whomever it is that's dying. Try to keep the environment calm. Maybe pull the drapes, or keep the drapes open but turn the bright overhead lights off. You want the room to feel calm and peaceful. This will help not only the person who's dying, but it may also have a calming effect on the family or visitors as well. Let the patient know that it's okay to sleep. They don't need to worry about talking or entertaining anyone. This is their time to just rest. If the family is overbearing or is making the patient increasingly anxious, then it's okay for you to be the bad guy and ask them to take a break or try to limit visitors. Even though it's important for family to be there, your job is to also advocate for your patient when they aren't able to communicate. You can likely tell by their vital signs if they're getting agitated. Maybe their heart rate goes up, their muscles begin to clench, or they start to shift around uncomfortably in bed. Those are all signs that they're either in pain, they're uncomfortable, or maybe they're bothered by something that's happening around them. As your patients become more socially withdrawn and have less energy, they naturally begin to sleep more. Whereas they maybe used to be awake for a couple of hours at a time, they may now only be awake for a few minutes and then fall back to sleep. However, it's important to know that they can still hear what people are saying, even if they can't respond or interact with others. Make sure you let families know this, as it can be beneficial in different ways. First, they can still provide comforting words and try to support the person who's dying. They can tell them they love them and that they have permission to die. Sometimes people who are dying are holding on, waiting to make sure everyone else will be okay. You can let them know, gently, that you'll be sad and you'll miss them, but you'll all be okay. That whenever they're ready to go, they can go. Second, the other reason you want family to know that the person can still hear is because you don't want them to say something that could upset the person or hurt them. If they assume they're unresponsive and thus cannot hear, they may talk about things that the dying person wouldn't want to hear, and that can create more anxiety for the dying patient. You can reassure the family that their presence is enough, that simply being there and being with the patient is comforting, that they don't have to do something or do anything right now for the patient. Encourage them, if they're comfortable, to just sit there, maybe hold their hand or stroke their hair, and just share that sacred space. Some pretty amazing things can happen when people are just quiet and together. One of my favorite nursing home residents when I was in college was a woman named Ruby. She had Alzheimer's disease and then got pancreatic cancer. She'd been nonverbal for quite some time, but was still very active. We'd love to dance to 40s big band hits, go for walks, even try to play simple card games, and watch Wheel of Fortune every evening. Suddenly, Ruby became very weak and fatigued. She started sleeping a lot and wasn't able to eat anymore. It all happened pretty quickly, really, within just a few days. I remember the last night I cared for her. I was working the 2 to 10 shift, and even after I clocked out, I came back to Ruby's room. I sat there on the edge of her bed, stroking her hair and gently rubbing her back. I had no expectations. I had no fears. Instead, I just opened myself to the experience, and what happened was amazing. Ruby and I had a 2-hour conversation with no words. Neither of us was talking out loud, but our spirits connected, and we were able to communicate openly in a way that had never happened before. I left around midnight that night, with Ruby at peace, and I knew she'd be gone by the time I came back to work the next day. And she was. It was beautiful. It was spiritual. It was perfect. She died as she had lived, as a caring woman with a gentle soul who touched the lives of many. Another thing that happens may actually be very subtle at first. It's very common for people to experience a gradual decrease in appetite and thirst. At first, it may not be very noticeable, but as it becomes more apparent that the person is not eating or drinking as much, the family often gets very concerned. However, this is a normal part of the body shutting down. The body knows how much it can handle, and the person will eat or drink if they feel the need to. Many families get very anxious, though, and they feel guilty that their parent or their loved one must be starving or they must be so thirsty. And oftentimes, they just need to know that it's not causing that dying person any pain. The body releases endorphins, which produce a numbing effect, in that they don't feel hungry or thirsty the same way that you or I would. Again, it's the body's natural way of slowing down and shutting down. Besides, their organs may not be able to handle it. If their kidneys can't process fluids anymore, for example, you don't want to force fluids and cause them even more pain and suffering. We need to encourage families not to try to force them to eat or drink if they don't want to. And we certainly need to make families aware of the risks for choking, aspiration, or aspiration pneumonia if they do so. If the person is not hungry but is still thirsty, consider providing them with a popsicle, ice chips, or frozen drinks as tolerated. Some liquids may need to be thickened. Eventually, the person will not be able to drink or swallow much at all, and in these cases, I'm a huge fan of glycerin swabs. I've included a picture here for some of you who maybe haven't seen them before. They're little sponges on the end of a stick, and you can dip them in water and then use them to gently swab inside the patient's mouth. A lot of times when people are actively dying, their mouths are open. I think some of it has to do with how they're laying down, but really how their muscles all begin to relax. And this can leave them with a very dry mouth. These swabs help to soothe their dry, cracked lips, tongue, and cheeks. Some are even flavored, so they have a little sweet flavor to them, which can be nice. This is something that family can do for their loved one who's dying, as they may want to still feel helpful or as though they can do something. The longest I've ever had a patient go without really eating anything was about 13 days, which was much longer than I thought was even possible. She was a sweet elderly woman with dementia in her late 80s. She was already very frail and fragile, weighing only 85 or 90 pounds. She had lost her ability to chew and swallow as part of her dementia disease progression, and she slowly became less and less responsive. She could suck on ice chips for the first few days, but then we could just swab her mouth with these flavored glycerin swabs every hour or so. She would sometimes smile subtly, and every once in a while she would try to suck on them, so it was good to see that she enjoyed and appreciated this small gesture, even at the end. Of course, every patient is different. When my grandma was dying of Alzheimer's, she was slowly, gradually declining. Obviously, her mental faculties were very limited at the end, but she had still been eating and drinking at meal times, passively participating in activities at the nursing home, and so forth. My mother used to go up every day to visit her, but she had to go out of town one weekend. When she got back, the nurses called her that next morning. They told her that my grandma hadn't had anything to eat or drink in the past 3 days, and they thought my mom should come up to visit her. She called me to let me know and to ask what I thought they were thinking. I gently let her know that if Grandma hadn't had anything to eat or drink for 3 days, that her body was probably shutting down and she would likely die soon. My mom was very worried that she needed to go up and try to convince her to eat or drink something, but I reassured her that this was Grandma's body's natural way of slowing down. That if her body was telling her she didn't need to feel hungry or thirsty, that she didn't need those things anymore. I let her know that Grandma wasn't in any pain. She wasn't hurting or uncomfortable because she wasn't eating or drinking, that it was everyone else who was uncomfortable about it, but that they shouldn't feel guilty. In the end, my mother called her sister, my Aunt Val, and they talked about it. They went up to the nursing home right away and were able to sit with my grandma as she very peacefully went to sleep and took her last shallow breath. She was comfortable, and they were comforted knowing they could be there and they had done everything they could to take care of her and love her every day. As I mentioned earlier, sometimes people who are dying might become a little restless, or they appear to be disoriented. This may relate to a lot of things. They might be in pain, they may be anxious, they may even be seeing people who have already died or having conversations with others that we cannot see. We talked earlier in this semester about nearing death awareness, and we'll talk more in coming weeks, but this can be confusing for family and caregivers. Don't argue with patients. Don't try to reorient them to time and place. Don't barrage them with questions to see if they know who you are or where they're at. Try to comfort them if they seem anxious. Listen to what they share, if anything, or just observe if they are having an experience that doesn't seem to make sense to you. Don't interrupt them. If they seem agitated, you can try to gently touch them or offer comfort. Sometimes they just can't seem to get comfortable, and the doctor may order Ativan or another anti-anxiety medication just to take a little bit of the edge off. This works for some, but it isn't always necessary either. One time I sat with my resident Luella, who was dying. She was all alone and had no family. She was sleeping a lot more, and I knew she was probably going to die in the next day or two, so I talked with my supervisor and asked if I could spend the afternoon with her. She was non-responsive, but I could tell she was kind of anxious at first, as she was a little restless and was fidgeting as she lay in her bed. I sat there in silence for a while, and then I began to sing to her. I sang her favorite church hymns. I held her hand. I prayed out loud with her because I knew that her faith had been an important part of her life. When I got tired of singing church hymns, I sang other random, slow, soft songs to her. She calmed down. Her breathing became less labored. She peacefully went to sleep. Luella didn't die that day, but the next day is when she died, and even though I wasn't there with her when she took her last breaths, I felt good inside, knowing that I had hopefully helped her to have a more peaceful passing. These moments are what life is all about. Accompanying someone as they die is such a beautiful, powerful opportunity to give one last gift. And yet at the same time, I truly believe that them allowing us to be a part of it is also a gift that our patients are giving to us. We learn so much, we grow so much when we stop trying to fix everything, when we stop trying to do something, and we just share that sacred space. These are the moments that stick with us forever and make us the caring, compassionate family members, friends, and healthcare providers that we're meant to be. Certainly, it makes sense that as one's body is shutting down, their internal organs would be slowing down as well. Many people produce less urine and fewer bowel movements as they approach death. They may lose control of those muscles and become more incontinent if they weren't already. It's important that we try to keep the patient comfortable, that we keep them clean and dry. Family may be worried by the appearance of the urine and think that there's blood in it, but it's not usually that at all. It's just that they're taking in less fluids, and thus their urine is more concentrated. As someone approaches death, their breathing patterns change. I've seen this happen in a variety of ways. Sometimes people's breathing becomes more labored, like it's harder for them to breathe. Others have slow breathing. Others have fast, shallow breaths that don't seem to move much oxygen in and out of the lungs. As they're getting weaker and their muscles are more relaxed, it's also harder for them to swallow their saliva or other secretions as easily. What often results is what is referred to as the death rattle. This is a sound that comes out of the mouth, deep in the throat as the person is breathing, because the saliva cannot be cleared from their throat. This doesn't hurt the patient or cause them discomfort, but it does certainly make family and caregivers uncomfortable because of the unpleasant sound, and it makes them worry. Doctors can order some atropine drops that the nurse will put under the patient's tongue, and this will help to dry those secretions, thus reducing the death rattle sound and making people more comfortable. There are other things that we can do too to help, such as elevating the head of the bed slightly, turning the patient's head to the side or laying their body on the side, or just letting the family know what's happening. Reassure them that the person isn't uncomfortable, but it just sounds concerning, so there are things you can do to help. Try to avoid suctioning the patient if at all possible, because that can be painful to the patient and even get them more agitated. When my paternal grandfather was dying of emphysema, they came into his room and suctioned his lungs again. It was awful. It caused him so much pain and anxiety, and he still died a few hours later. It would have been nice if they just let him rest comfortably. One of the other things you may notice in your patients is that their color may change. As the body shuts down, circulation slows down, and you don't have blood getting to the extremities like it used to. The result is that the skin may begin to look mottled, or this kind of purple blotchy pattern as we see in the picture here. This is just the blood pooling in the capillaries, and the person's feet or legs may begin to feel cool or cold to the touch. That's just because the blood isn't circulating there anymore. Their heartbeat is slowing down, it's getting weaker, and it may become irregular. This is the body's natural way of shutting down, and again, we just need to explain this to the family so they know. There's nothing you can do to increase circulation, but you can make sure the patient is warm, possibly covering them with a blanket. They may also have a different smell to them. This is partly due to physiological changes that cause their sweat or perspiration to smell differently. They may also have a different smell coming out of their mouth as they breathe. This is usually a very distinct, sweet, pungent smell. It's the smell of death. For anyone who smelled it before, you know exactly what I mean. It's very unique, it's kind of hard to describe, but oftentimes this smell is what helps indicate that death may soon be approaching. I've taken care of patients before where I literally was hit with a wall of this odor as soon as I walked into their room, And then we knew it was time to call family and start making preparations to ensure the person was still comfortable and pain-free. Other times it comes on more slowly, and sometimes you don't even notice it unless you leave their room and come back in, since you may have just grown accustomed to it over time. Families may be concerned, or they don't know what that smell is, and it's okay to let them know that this is a natural smell, and it's just an indication that their body is slowly shutting down. So what does the actual dying trajectory look like? How do we know when someone is going to die? Well, we never know exactly, but we can certainly look for indicators that may suggest about how much time is remaining. Death can be slow and progressive, or it can be slow and progressive, then quick, ending with an acute event. For example, think about people who are declining due to cancer, but then end up actually dying from a stroke. Or people who are slowly dying of dementia, but then die from a heart attack. This can be confusing for families, as they may feel as though they thought they had more time with that person, and they weren't yet prepared for them to die. Even when someone has a terminal condition, it doesn't always mean we're prepared for how and when they will actually die. But if we look at some generalizations here, we can see a progression of symptoms of what often occurs as someone's body is shutting down and they're getting closer to death. In the month or so prior to death, we may see the patient or resident becoming more withdrawn. They're less social and they're sleeping more. They may seem like their body is there, but their attention or their mind is somewhere else, as if they're going inside themselves or are becoming more detached from the outside world. As a result, they may communicate less with others around them. As time progresses, and they might be a week or two away from death, we may begin to see them becoming what seems to be disoriented or agitated. Their blood pressure begins to lower. Body temperature may fluctuate. They might sweat more and start to have some skin color changes. They may begin to breathe differently as well, as we discussed a few moments ago. As death becomes imminent, it's actually not uncommon to see a sudden surge of energy. I've actually seen this a lot. Someone is deteriorating, family is preparing for their upcoming death, and then all of a sudden the person gets this burst of energy and they're talking more, they're alert and they're more active, and the family thinks, oh wow, they're not dying. Maybe they were just really sick and look, they're going to make it. Yay, everything is great. And they feel a sense of relief. Well, that could be, but most of the time, it's just this unexplainable phenomenon that occurs right before someone dies. In my own experiences, it's usually within 2 or 3 days from that burst of energy when that person actually dies. Also, just to note, not everybody will have this increase in energy, but it is quite common. Aside from that, their eyes may be open or partially open. The person is likely becoming less responsive, and you can tell that they're becoming more congested or having a harder time clearing mucus, saliva, or other secretions from their nose and throat. They may have changes in urine and bowel output. Their pulse may be weaker and harder to find, and you may notice that their feet or hands are becoming mottled. That mottling, or that blotchy kind of purplish pattern, will move up the body as circulation decreases. So it will usually start in the feet, maybe the hands, and then as the person gets closer to death, that mottling may move up higher on the legs and towards the abdomen. This can be a very good indicator of how much time the person has left. If it's a couple days, maybe, or oftentimes just a few hours. Once that circulation stops nearer the heart, the person dies, and that's why we don't see mottling all the way up to the heart. Finally, someone may be what we call actively dying when they are in those last few hours or maybe the last day or two of their life. This is where many of those symptoms we mentioned earlier become more intensified as the body shuts down. At this point, they're not likely to be eating or drinking anything anymore. They may be nauseous or vomiting. They may be restless or confused. They become less responsive and are often unable to communicate verbally. This is where we hear those secretions, that death rattle becoming more pronounced, And this is where you may notice that smell of death on and in their body. How they die cannot always be scripted, but we can do what we're able to keep them comfortable and pain-free. If they want to be alone, they can be alone. If they want to have someone with them, then be sure someone is there. And if they don't tell you otherwise, I always assume that most people don't want to die alone. And then we can try to be sure that either ourselves, a family member, or even another healthcare provider are present with them as they die. So as we wrap this up, what can we do for their family? Well, I've tried to provide specific ideas and suggestions on each of these slides for you, but generally speaking, we have an opportunity to educate the families about the dying process and what they may expect to see changing or happening. We can let them know of any cares that may be able to provide for their loved one, and we can be there to answer questions they have. Sometimes we don't have the answers, and that is okay too. We need to try and make it easy for them to stay with the patient as long as they wish. We don't want to kick them all out or force them to stay. Let the family and the patient guide you. Keep the family updated of any changes in the patient's status, especially if it appears that they'll be dying soon, because the family may want to notify others. They may want to also perform a special ritual or prayer or other tradition that is important to their family. Allow the family to be involved if they're comfortable doing so. You may also have other ideas of what family members can do to help, maybe things that you've had in your own life experiences. As you think about this and the steps we've just covered, I hope this is helpful to you and is something you may come back to and reflect on in the future.